Hi and welcome to Lessons from the Grand Rounds. This is yet another session of interesting cases in clinical hematology. This is a case from a medicine residency while I was a medicine registrar. I get a call during my emergency day from one of our medicine consultant regarding a case which is there in the minor OT in the urosurgical department. So they want a referral for high TLC count while the patient is presented with painful penile erection or priapism since the last 4 to 5 hours. Young male, 18-year-old, he was working as a construction worker and then he had spontaneous painful penile erection. From the last 5 to 6 hours, he goes into the surgical ER. The patient is taken up by the urosurgery department and basic labs have been sent. The CBC has hemoglobin of 9.2, 5 lakh counts, platelets of 85, 8 lakh 50,000. And we are being called the first differential would be to rule out acute leukemia. On examination, the patient, apart from priapism, just has a spleen of around 8 centimeter below the left costal margin. On the peripheral smear on examination, you see that there are just 3% blasts, significant basophilia, 12%, eosinophilia, myelocyte, metapilocytes. So with the suspicion of CML, chronic myeloid leukemia, BCR-ABL is sent. The patient is started on IV fluids, Hydrea 2 gram, 4 hourly started, and apart from that, we give him febuxostat pain management. From the urosurgical side, for painful penile erection for around 6-7 hours, they initially perform corporal aspiration and irrigation, but 3 to 4 hours later, the patient had significant pain and the priapism was not relieved, so he was taken for an operative for the corporal shunting. Post-op, we review the patient. We were seeing the TLS markers for every 6 to 8 hours. The patient was not in TLS, and then we took over the patient. And over the next 3 days, we titrated the dose of hydroxyurea, IV fluids, and other parameters. And the TLC came down. 4 days later, the BCR-ABL major transcript of P210 was positive. Patient was diagnosed with CML. So this is a case of CML presenting as priapism as a result of hyperleukocytosis with leukostasis um, leading to the venous outflow obstruction of the corpora and hyperviscosity signs. So this is not very uncommon, but then during my residency, I had seen 3 to 4 cases similar, which presented as an hematological and urosurgical emergency. So in such cases, we have to rule out acute leukemia. We have to uh, cautiously cytoreduct the